So we'll just start in a minute. So today is going to be the first class. So welcome to the online course for MRCS Part B. So Dr. Rohan and I will be the course coordinators, and we will be guided by Dr. Dheeraj Haribau Kachare, Dr. Praveen, who is a renal transplant surgeon from the UK, and Dr. Praveen Shekaran, who is going to be a colorectal surgeon, and Dr. Kumar, who is an orthopedic surgeon. And we'll have other faculty as well, like ENT faculty, vascular surgery, to teach you very specific aspects of the course. So one thing I can assure you during this course is that you will be given personalized attention, and you will be made to practice almost all the stations. Our previous online course had an excellent response. Some of the students from the previous course have decided to attend it again because they want some a little more experience. Many of the people who attended the course have done really well, passed, and I'm super delighted to note that fact as well. So there are a couple of things I need to. Dr. Dheeraj will be giving you an introduction about how the exam happens and general part of it. But I'll just be talking about what do you need to do to do really well in your MRCS part. So first things first, MRCS Part B, the preparation time you need is much less than Part A. Okay. The knowledge you have gained in Part A is going to be super useful, especially in areas like pathology and anatomy. Just like Part A, I keep emphasizing, many of you I can see are my Part A students as well, is that anatomy is going to be a very important component of it. So that is one aspect where you don't need too much guidance from me or a mentor to study. So that's something which you should start studying right from day one, because anatomy, the questions can be extensive. Questions can be from anywhere. And there are a couple of books. I will tell you the names of the books. One of them is called Vishi Mahadevan. It's a green color book. You can order it on Amazon. PDFs are also available. There is another book called Manoj Ramachandran. They are essentially OSCE stations about how the exam is going to be asked. To revise anatomy, you will have to use resources such as Netters or Thymes Atlas. I prefer these two atlases. And I usually, in my Vishi Mahadevan, I used to make a note of which page that, that particular topic is going to be there in or not. Then there is pathology. Pathology, we will be giving you some material to read about. It is going to be extensive. The one change which has happened since, say, 2018 pre-COVID is the fact that your MRCS exam pathology parts have gotten much more tough. Before, when I wrote my Part B, I wrote my Part B about, say, 7 years ago. I think it was 2018. I wrote Colombo. For a very long time, we didn't have the Colombo Center at all, especially after the Sri Lanka downturn and everything. But it was an excellent center. But pathology was an easy station. There would not be too many complex questions from pathology. Right now, there has been a new emphasis on malignancy and also diseases which are seen in the tropics because of immigration. So the MRCS Part B exam is designed for the UK audience. Okay. So till, say, pre-COVID, the questions would be the kind of diseases you would see only in the UK population, IBD, side effects of corticosteroids and all that sort of stuff. But right now, what you're trying to say is that we are seeing diseases which are seen in the tropics. Like I see a lot of questions on tuberculosis, Part B stations on tuberculosis. I see Part B stations on gastric cancer, which is a rare entity. And I also see a little bit emphasis on oncology topics. I think for those of you who have written Part A through Mortimer Green, you would have seen the Mortimer Green question bank and the emphasis on, oncology, so some of the tougher topics. And the older question banks, many of them don't have that emphasis. But that is a shift which the entire Royal Colleges are taking. So there are going to be a few more tougher questions on lung cancer, gastric cancer. These are all stations which are commonly emerging. One point which I forgot to tell you when I was talking about anatomy is that vascular anatomy is going to be super important. Now, that's a topic which you might not have studied too much in your Part A, which means that you will have to understand how do you read a vascular, angiogram, a CT angiogram or a MR angiogram. And that is for every set of blood vessels, right from the brain, head and neck, thorax, abdomen vasculature, upper limb and lower limb vasculature, you should be in a position to identify every vessel in a MR or a CT angiogram. And that is something which, your textbooks will not be able to help. Get on Radiopedia, check out the images in Radiopedia. We'll also try to see if we can teach you that as well. So that's a class which I promise you that I will incorporate in this session. One thing which I promise you in this session is that you would have seen the brochure, there's 10 classes and all that sort of stuff. But that is not a fixed concept. It is going to be fluid. There are going to be many more classes, to be honest. There are going to be much more than 10. So, we will have multiple sessions where we'll be clearing your doubts, answering questions, going back. So if you come back to me and say, Sir, Malaysia 2024, these are the stations which came and we are struggling, I will be arranging a separate class to, exclusively address that. So that's something which I can promise you. And, I would want you guys to be actively participating in the group as well. There's a group for the participants. So I would want you to be participating. I want you to come out with information wherever you see you are there in a lot of forums actively. Someone will say you, okay, this station came up. So I want you to come back to me and tell me if this station is there. So, I want you to understand, I want you to understand this particular thing. The most important thing a lot of participants fear is procedures and examination. But one thing I can assure you is that procedures and examination is not where Indian students actually fail. It's communication and history taking. There's a reason for that. When it comes to communication and history taking, you do well. You communicate in a way which you feel is the right way to communicate. But what actually happens is that you fail because you don't know what mistake you have actually made. You might have said something. You might have behaved in a certain way. Your actions would have indicated certain things, which means that the lay examiner, there's going to be, see, one thing you have to understand, Dheeraj will be explaining to you in this in detail, but one thing you have to understand that in this communication station, there's someone called as a lay examiner. Now, this lay examiner is not a doctor, could be a medical student, mostly an actor, English professor. So many of you are going to come to Chennai. There are going to be actors from a leading English drama troupe. They're going to be English professors from local arts colleges. So these are very friendly people. And these people are going to assess you not on the medical aspect of it. They're going to assess you on how you talk, how you behave, whether you are able to demonstrate empathy. So you might have said something, but that might not be the correct way to demonstrate empathy. So I'll give you a simple example of why students fail. Okay, I'm going to be teaching you through the class. I think it'll be today or tomorrow itself. I'll try to teach you. How do you sit in a thing? So a lot of you guys, are you guys unable to hear?
We can hear, sir.
Okay, I think I got a text saying that they are unable to hear. Maybe I think they should check it. Yeah. So, a lot of us tend to spread our legs and sit like this. Now, if you, at some point of time, during your examination, if you spread your legs too wide, now for the patient who is suffering from a medical condition, who is trying to explain the condition to you, that demonstrates lack of empathy. If you sit back two legs in a chair like this, what kind of feeling do you get? You might be sitting like that because you want to feel relaxed or something. Or if you come at the edge of your seat like this, that demonstrates you are anxious. So there is a correct way of sitting. I'm going to be teaching you that as the class progresses. How do you sit? How do you talk? If a patient is getting angry at you, how do you respond to this situation? Do you ask the patient to calm down? See, there are certain phrases you should not be using. Okay. I think I can see that many of you guys, how many of you guys have a girlfriend or married guys? You don't need to answer me. It's okay. Some of you girls might be married or might have boyfriends. But one phrase you should not use if you've been in any sort of relationship is you can't tell your girlfriend or your partner to calm down. Okay. And now that applies for you during your MRCS exam as well. Don't tell them to chill. Don't tell them, please calm down, Mrs. Smith. Please calm down, Mrs. Rangan. None of that sort. Okay. Because that shows that you're condescending. And so these are phrases which come, a patient is agitated. Please calm down, ma'am. Because that in the UK perspective, that means that you're being condescending. You're being arrogant. Now, there are ways of handling this, and that's what you're going to be doing during this class. And there are certain cultural aspects you will have to understand. See, one thing you will have to understand is that the MRCS is set in UK. Okay. And UK is a multicultural society, which means that there are people from India, Pakistan, Bangladesh, Egypt, there are people from the US, there are people from the West Indies, Grenada, there are people from Australia. So it's a very multicultural society. And so there are certain cultural sentiments you should respect when you're talking to people, which means that there are people from all religions and every religion has its own sentiments and which you should be respecting if you wish to pass the exam. So you cannot go, if someone is getting agitated, you cannot go and pat them on their shoulder. Now, that is something you might be doing in your practice in your hospital in Pune, Chennai, or wherever in Dakar, wherever, whichever part of the world you are in. But now that is not something you should be doing in your MRCS Part B exams. Because what you are doing in your hospital is something which is culturally relevant. See, one thing I want to tell you guys is that I respect all of you guys a lot. And it means that most of you are actually fantastic physicians and surgeons, which means that you, whatever practice you're doing in your hospital is very culturally appropriate for your setting. But now there are certain good things you can learn from your MRCS Part B preparation in trying to understand. So communication and history taking are going to be a major focus of this. And in communication and history taking, I'm going to be personally leading you throughout this thing. And when it comes to communication and history taking, there are a lot of subtle nuances. Both of them are not the same. In communication, you are the information giver, and history taking, you are the information receiver. So there are going to be certain ground rules for following in communication. And I have a very specific way of functioning. So this course, I'll tell you, all of you are attending this course, there are certain ground rules. The ground rules is that all of you call me by name, which is Vinayak. Or if you feel very uncomfortable calling me Vinayak, you can call me Dr. Rangan. Okay. And you call each other by name also. So I see some people, some of you, some of them have been my seniors, some of them have been my teachers, colleagues I'm a pediatric surgeon. So, I see some of my colleagues over here. I see some of my friends over here, juniors over here. So for everyone, the rule is same. Okay, so if I see Dr. Zoheb, I call you Zoheb. If I see Dr. Ashutosh, I call you Ashutosh. If I say anyone, I'm going to call you by name, which means that you also will have to do that to me. Nobody calls me sir, because in the UK system, when do you call a person sir? Can someone answer in the chat? When you've been knighted by the king. That's the only time you're going to be calling someone sir. Okay, so that is the same rule you're going to be following during your examination. I am not saying this to break any sort of hierarchy. I have no major intention of changing your social setups. My intention is to prepare you for the exam. My intention is to make you pass the exam and do really well. That's my only intention over here. And so I will be tuning your entire mindset towards that. And I'll be giving you certain tips. I'll be telling you how to talk, how to communicate, how to write a consent, how to explain a consent for endoscopy, colonoscopy. And there are certain rules. You will have to go back to your hospital and practice the same thing. The language doesn't matter. You can explain the same consent in Tamil, Hindi, Marwadi, Marathi, whatever language you're comfortable with your patient is. But the way you're going to talk, the way you're going to sit is something you have to practice. And I'm going to tell you, this was my personal experience. I started this course in 2019. Uh, and I passed my MRCS when I was a MS General Surgery resident in 2018, final year. And I used to practice with my senior, Dinesh, who was a urologist in the same hospital, urology PG in the same hospital. He was my, when I was an intern, he was an MSPG too. And we had a set of specific, simple rule. He used to teach me a lot of stuff. I used to discuss a lot of stuff with him. And we used to go back and, behave the same way with our patients. And that's how this course evolved. Me and Dr. Gopi started this in 2019. The same simple set of rules. We do exactly the way we practice the same thing with our patients the same way. Okay, so that is a major rule. The second rule which I will be having is that I will be giving you homework. Okay, and that homework is sacrosanct, which means that if you are not doing the homework, I will not be teaching you, and I'm going to be very strict with this. Okay, these are going to be simple tasks. Okay, and these are not going to be written homework. I'm not going to be giving you written homework. I will ask you to record certain stuff. So a small video. Is my video being clear, Ankur? Audio and video?
Yes, sir.
I'll be giving you certain homework. I'll be asking you how to greet a patient. You'll have to record it and practice it and send me a small video. I'll be giving you a Google Drive link. You can upload it over there. And uh, all of you have to follow it. So there are a lot of people attending the trial class. If you feel that, I know I cannot do homework, I'm going to be a silent participant in this course, then this course is not for you. Okay, this course is for people who are going to be committed, people who are intending to pass. I don't intend to make you spend a lot of time. So this course is going to be recorded. If you miss a class, the sessions are going to be recorded. That's all okay. But if you've attended and I've given you homework, you will have to do this. So there are two rules only. You call each other by name. And second rule, follow the homework. And two, listen, make maximum use of your mentors today. Okay. So I have with me Dr. Dheeraj. Hey Dheeraj, are you there?
Hi, sir. Hi, I'm here.
Yeah.
Yeah.
Okay. I think so a small introduction about Dheeraj. Dheeraj is an oncosurgery resident. He is a very enthusiastic. He was a very enthusiastic student. He attended our classes. He attended our offline course in Delhi. He passed, and he managed to have, after finishing his course, he managed to guide a lot of his friends, his seniors, even his professors, and he has joined as a faculty over here. And I'm very proud to say that Dheeraj is one of the best faculty over here. He's going to be absolutely truthful to you. He's not going to mince words. If he says that you're wrong, you are wrong, and if you're done right, he's going to be telling you. So he's going to be a fantastic mirror to all of you guys, because he's going to tell you exactly what you're doing. Okay, so please listen to Dheeraj. Dheeraj will give you today an overview of the examination, overview of the entire MRCS Part B examination. After Dheeraj finishes, I'll be just doing one station today in communication. That's just the basic introduction. Okay, so shall we start, Dheeraj? Are you ready?
I'm ready, sir. Yeah.
Yeah, yeah,
I'll
yeah.
share my screen.
Absolutely, ma'am.
Yeah.
Hey, thank you so much, guys.
So, good evening to those who have joined, registered to our MRCS Mortimer Green Part B course, and to those who are in the trial class. I mean, I'm pretty sure that you will be joining the course after listening to what we are going to do. So, what exactly is MRCS Part B course is something that my friend and my junior had asked me a long back. And when I gave the exam, I realized it is nothing but a rehearsal for you to fit yourself in the NHS way of training. That is about it. How difficult is the exam? How much time duration to prepare? If you are from an average medical school in India and you are an above average student, I think 10 days is the enough time for preparation of MRCS Part B. People feel that this is an exaggerated timeline. I myself, when I was preparing with Mortimer Green, I thought that 10 days is something that is just being told to make it seem easy. But I did my Part B when I was a first year resident, and I had a leave of about 7 days. And I did that preparation and I cleared in first go. The important aspect of what we do at Mortimer Green is we find out and analyze why Indian students fail at the exam. And what we have observed in the last few years is it is mainly because the communication aspect and the empathetic aspect, how you respond to a sad news and how you communicate with the actor, the patient, or the colleague, and how your general demeanor is towards the patient. What we have not been taught in our medical school is that we don't usually uh, give in to what the patient wants. We just follow what we know and we just lay our decisions on them, which is 90% of what the government medical colleges as residents we do there. I see a fair group of diverse audience. I think we have been teaching students who are post MBBS, who are post MS, who are post MCH, who are in their MCH course or DRNB course, or who are in their MS course. The best time to give MRCS Part B is, I think, post MBBS, because no one has that. Those people do not have to unlearn their habits because they don't have one. The difficult is the most difficult is the post MCH, who are almost thorough with all the guidelines and all they know is what to do and what not to do. So we are going to tell you how to appear for the exam, if you are an MCH, if you're an ortho resident, if you're an ortho post-ortho consultant, we have been successful in getting the people, those who have faltered multiple times in the exam, to clear the exam. So without further ado, I'm just going to give you a quick overview of what the exam is going to be about and how we are going to help you out in through the online module of the Mortimer Green coaching class. So I'll begin. I have a few credits to my friends from my MS days, Bala and Parth. I have borrowed a few slides from them. So this is what I always tell people who start preparing for the MRCS OSCE part. You should have this in your study area where you should know what marks are distributed to what part. So basically, it is divided into two broad specialties. One is knowledge part and one is skills part. The knowledge part, we can't help you out much, but yeah, definitely we'll tell you what to read, what topics are happening, which was the previous year questions that came, what was the stations that were asked recently. So these the questions that are frequently asked, we can help you. But I mean, it's difficult to teach anatomy at this stage from the basic. So these anatomy, pathology, microbiology, part of immunology. This is what you have to do on your own. We will be hand-holding you. We will be taking practice sessions, one-on-one sessions. Whatever doubts you have, we are there to solve. We will tell you which books to refer when. If how early you are in preparation, if you have 3 months, 4 months before your exams are booked, or if you have a 2 weeks, 3 weeks time duration, we'll tell you what to read, what not to read, what to avoid reading. So there are a lot of materials available in the market, and we will tell you what to read. We have our own notes, set of notes. We have the exhaustive pathology notes. I mean, I don't think there is anything asked out of that pathology notes. So we have that exhaustive. We refer to a book called Vishi Mahadevan for anatomy, and we'll give you the part booklets for communication skill, for the history taking, for the examination. So without wasting time, there are in total three anatomy stations, two surgical pathology and microbiology stations. There are all three critical care stations. Then there are two communication skill stations, three examination stations, and two procedure stations. So that amounts to roughly around 17 stations, plus one station is usually given as a rest station in between this. So your stations are for 10 minutes. Few stations you get the entire 10 duration for your say for example in a communication station you will get the entire 10 minutes for the exam, the assessment part, while in the anatomy as well you will have the same thing. You will surgical pathology, you will also have the same thing. The problem of this split occurs in the communications part and sorry, the skill part and the examination part. So that is divided into 7 plus 3. So 1 minute you will have to read the stem, then you enter the station. Stem is basically, if the word is not familiar to you guys, it is basically the scenario which is given to you outside the station or outside the room. And then you read that, you understand what they are expected of you. Then you go inside the room. The timer has started. For 7 minutes, you get to assess the exam. If it is an examination station, you get 7 minutes to examine. Then there is one bell which happens at 7 minute time, and then you have to finish your exam, and then you have to answer the questions in the next 3 minutes, which the examiner will have for you. The Most of these stations will have only one examiner. There are few stations which will have two examiners, out of which one examiner is a lay examiner who is not from surgical background. He or she may be the professor of English. He or she may be doing some other social job. And the other examiner will be the surgeon examiner. The surgeon examiner can be anyone. He can be an orthopedic surgeon. He can be an anatomist who is practicing in UK. Anyone. So it doesn't really matter how much you understand about the exam. It is important to understand that every candidate on the given day and in the given session will have the same set of questions. No one will have any out of the blue questions like we do have in our Viva Voce. It's not like that. It is structured exam. If anatomy station has 20 questions, All 20 questions will be asked to same 20 questions will be asked in that session to all the candidates that are appearing in the session. So it is important to understand that there is no personal bias here. The examiners themselves are being examined in the exam. So there is one invigilator for the examiners who he roams around in every station one by one. So you will have him in one of your station. Now, what happens is the lay examiner, people tend to underestimate or tend to not calculate the lay examiner. The lay examiner makes a huge difference. So, if you see into the skill broad content on the right half of the screen, in the communication skill, you will see one communication has 12 and 8 marks into the two stations. So the 12 marks into the surgeon plus lay examiner is into the hands of the lay examiner. Out of 20, almost 8 to 12 marks are in the hands of the lay examiner. What does the lay examiner look? He looks into your body language. He looks how you are communicating with the patient. Are you anticipating and solving the patient problem? Are you empathetic enough? Are you offering any painkillers to the patient who is having pain? Are you empathetic enough to understand that the person is concerned about the pet at home despite having a comorbid or nearly advanced stage cancer? So these things, how you react to what the actor is saying, how you make changes in your tone of your voice. So these all things, little things we are going to teach you throughout the course, and there are multiple practice sessions. So I think if you are active enough, these classes plus 10 days of preparation is enough. If you're not active, then it is difficult to do it in 10 days. So I think everyone should participate whenever the Dr. Vinayak will be taking your session on communication, and you will understand the difference of how things happen in the exam. So this is what the most important thing. So we'll move to 118. I'll be very brief about it since you have another class after this. So anatomy has three stations, and surgical pathology plus microbiology will have two stations. Anatomy station, usually the examiner will have two images in one station, and like this there will be three stations. So you will be asked, mostly it is about neck, the back of thigh, the side view of the thorax. So these things that are shown into the picture form is given. So it can be an imaging, it can be a CT angio, it can be a bone, image of a bone, it can be a prosection. So how to prepare? Anatomy, you should be thorough with your textbooks. We'll tell you which topics to go ahead and read. Mostly it's junctional anatomy. So the neck anatomy you should know. The groin anatomy you should know. The popliteal fossa anatomy you should know. Back of thigh you should know. The thorax anatomy you should know. You can, if you have a bone set, fairly well. If you don't have, you can use all the 3D apps that are available now. Atlas, we usually recommend Macmillan's Atlas, which is the closest to what we find into the exams. But in last few exams, it is not so. So, I mean, Macmillan's is a great way to practice, but you still have to be attentive enough in the exam to understand what the examiner is trying to ask. So this will be a diagram in the exam. The arrows are labeled now. So they will be labeled as A, B, C, D, and then the examiner will point at one of the labels and ask, what is the structure? So this question will be a 1 mark question. Like this, he or she will be asking you 20 questions. There will be no questions out of the set. The examiner will have a pink sheet in his hand, and he will ask you those 20 questions, and only those 20 questions. He will not ask anything else. The trick to this is people try to answer every question in sequence, and then they lose the time, 10 minutes time. It is always better to ask if you can pass and come back to the question later. Sometimes the next question might be an answer to the previous one, so the examiner will deny your request and say that if you do that, I cannot come back to the question. Then you can guess the answer. If it sticks, sticks. If it doesn't, then you lose that because anyways you are not going to be able to come back. Be smart about your exam. Make sure that you are present in the exam and not you're not thinking out loud. Even if your one of the station goes bad, there is saying in MRCS exam, you live every station and you die every station. You have 17 lives. make sure that you make the most of all the 17 lives in in the exam. This is the foramina is one of the favorite questions. Then the celiac trunk, the gastric vascular supply is another favorite question. So these pro sections, this image of the skull bone, image of the open cranial cavity will be kept, and you have to answer accordingly. Then there are multiple questions on origin incision and the course of vagus nerve, which muscle to divide while approaching the superior pole of thyroid gland in thyroid surgery, which are the structures that are attached to greater trochanter, which are the structures attached to the anterior superior iliac spine. So these all things they will ask. That is about anatomy. Most of it we will be giving you the material, but I think you have to do this part mostly on your own, 80 to 90% on your own. We'll guide you on what to read, how to read, when to revise before the exam, and what all things to keep in mind before you enter the station. Moving on to surgical pathology, it is like a question answer station. The examiner, the STEM will have a scenario of, say, a 30-year-old immigrant from India or from one of the South Asian countries is complaining of cough with swelling in the neck region. The FNSC has came out to be multilocular, FNSC or biopsy has came up to be um, say giant cells and Mycobacterium tuberculosis has been identified. So you will have the entire question on Mycobacterium tuberculosis. Sometimes they club the stations with endometriosis and sarcoidosis or endometriosis and diverticulosis. So these they can uh, put together. Sometimes it can be about microbiology. Few questions will be about microbiology. So you need to understand and learn these aspects. Some stations, some questions are very pretty straightforward. How will you dispose the infective sample? Which bag will you use? Which code will you use? So these all things, if you don't know, then you won't be able to answer. So that is why a class is essential. People who have been mentoring or tutoring these kind of exams, you should come in contact with them. You should discuss. This exam is not to be appeared after practicing individually, because then you won't understand what you're making mistakes of. So we will be very partial and we will be very impartial. We will tell you whatever you're making mistake at point blank at your face, so that you understand that the changes that you need to make. If you haven't booked your exams, please book your exams and start your preparation, because preparing without booking exams is a very a lazy job as a surgeon, and people don't tend to do it. So I would advise book an exam which is available, and then you can start your preparation. 1 month is more than enough, even if you don't have no ABCD of the exam. So I think you can book 1 or 2 months away from now if you haven't booked. If you're booked fairly well, please let us know your exam dates into the chat box or into the group for people who have registered. For surgical pathology, I told you it can be a mix of immunology, hematology, a bit of general surgery, and a bit of microbiology. These all stations are most frequently asked. We will be guiding you through the most common ones and we'll tell you which ones to read. If you are from an oncology background, this part becomes a bit easier for you, because then you don't have to understand or remember the certain mutations or certain the treatment part of this. So this pathology question usually ends in how will you treat this patient. You have to understand what the it is from the basics of how will what you will see under the microscope, what all is expected of you to see in the report. The post-op report is there. Please counsel the relatives. If it is an R2 resection, then what will you tell? So these all things are in this session. You don't have to much worry about it. If you read it once, it's enough, but you should read minimum once. What are the sources? Mostly NCCN guidelines and TNM staging for Oncolo part and Robbins for the rest of the part. We have made an extensive resource of that, which will be shared onto the group by Dr. Vinayak or Ankur, and then you can understand. These are the sample questions. They'll give you some image. They'll tell you that this is a FNSC picture of something, something. Usually it is very easy. These exams, these are scoring points, and everyone in the Indian scenario, Indian candidate who gives the exam scores well in this scenario. So we don't have to much focus on this part. But yeah, if you have long read back pathology long back, I think then it is your time to start revising. Then moving on to critical care, this is a mix of ATLS plus CCRISP, if you are aware of it. So CCRISP is care of critically ill surgical patients, and ATLS is advanced trauma life support. Anyone who has given ATLS has an advantage of this if the trauma part comes into any of the three stations. If not, it is mostly a CCRISP station. Now, while preparing, we prepare like this is a CCRISP station or a critical station, this is a history taking station, this is the examination station. But this is not what happens in the exam. In the exam, you have to identify which station is what. And it is difficult to understand what is a secret station and what is a examination station. So the general rule of thumb is if you have accessories into station, if you have images, if you have blood chart, if you have the temperature chart, if you have all these things, it is a care of critically ill surgical patients station. And if it is a hot case, acute case, it is a secret station. If it is a cold case, then it is probably just a physical examination station. If you're lucky enough, it will be mentioned outside the door, but usually it is not. So I'll come to the critical ill parts. This is divided into 12, 4, and 4. So professionalism, decision making, problem solving, situational awareness, judgment, organization and planning, and patient safety. See, the problem is when patient expresses the concern, it is your duty to solve the problem. It is your duty to be aware of the situation. Your duty of so that should reflect in your response to whatever the excuse me to whatever the person is asking of you. If you are not good in planning, you are going to lose 1 mark. If you're not, there are basic some things you should not miss. You should always enter the station, wash your hands, or act you're washing your hands. Enter the station, greet, make sure that you introduce yourself, you confirm the identity of the patient with name and age or name and date of birth, whatever is available. You make sure that you establish a rapport and then you proceed. And every time you are giving a consultation, you should close the consultation. You should not abruptly turn when the 7 minute bell goes, and you should not abruptly turn without thanking the patient towards the examiner. That is not professionalism. That is not respecting the person's time. So these all things matter. It was difficult for me to understand initially, and since I was doing my residency, first year of my, I'm still doing. I was a first year resident, so I did not have much of time. So the last patient in the OPD was my guinea pig, and I used to uh, practice my stations on him. Whenever I was explaining consent, I used to make sure that I try to inculcate what all points are there. And this is how you practice if you are in a practicing consultant or you are a resident. You can definitely do it. It is not something that has you have to take separate time out of it. If you have the leverage of doing that, very good. If not, it is an exam that is easy if you prepare it in the right way. So these all things can come trauma, medical emergency, surgical emergency, ICU management, anesthesia related, and complications of procedure. So these all things are almost 29 stations here. It is nothing out of it. The beauty of MRCS exam is that the exam is repetitive. Rarely they will introduce any new station, and usually those stations come into the UK exams, and then they are given into the Middle East, the and the South Asian countries, seeing how the people, how the candidates over there clear that station. So this is what I was talking about ATLS and CCRISP. This is an example of a tracheostomy patient and what to do. There can be an ICD session for you, but so every station is interrelated. If you read enough, you will understand that this can be helpful into the procedure station where you are going to insert an ICD into the patient. So these all things are interconnected. The most difficult part for any surgeon is to read an ECG, or in any orthopedician is to read an ECG. So if you are someone like me or not is not uh, very happy to go back and read ECG, you can always answer that the ECG finding is an atrial fibrillation. That is what I had decided. So I did not read much into it. Although I did read some basics of it, but then you should know acid base, electrolytes, chest X-ray, how to read a chest X-ray, what is the format. If you are structured and you answer in format, then you get marks into the exam. It is like a math exam. For each step, you get marked, and you should not miss any step. Even if you reach to the answer that this patient has bilileak post cholecystectomy, you're not going to get marks if you don't follow these steps. So that is what I want you to understand. And we are going to help you out to understand what step is crucial, what is expected of you at this station. And then we'll move on to ahead into the nuances of the exam and what to do, what not to say, when to cut the patient, when not to cut, how to cut the conversation, if at all it is needed, if the patient is wandering around and you are losing your time. These are the few examples. You should know the charts, you should know how they record. This is one of the examples, scenario one, when HDU, you are asked to review a chest X-ray shortly after starting a night shift. The nurse informs the patient was admitted here 2 days back, has underwent a laparotomy for sigmoid volvulus, had a 3 week stay on the intensive care. Nutrition has been difficult, and NG tube fell out, and now the other doctor has placed it, but has now gone home. Kindly look at the X-ray. These are situations which are given. This is how the examiner will mark you. So it describes the checks you would perform before assessing the clinical aspects of the claim, the name of the patient, date of the birth. So you have to identify 1 mark for this. Outline the system you use. So which do you use, ATLS ABC system, or you use bone or soft tissue, or which other system you use? So are you able to assess the projection, that is a AP view or a PA view? How do you assess if the film is rotated or is in a midline? So these all things, little bit things matter. I mean, this is what we help you out to understand what you're missing. And then there will be a few questions in the management aspect. You should ace your knowledge section. There is no doubt about it. If you do not ace your knowledge section, it is a bit into communication session as well, but knowledge, I think you can't miss. It is pretty difficult to uh, pass if you have an average knowledge score into the knowledge section, because everyone does pretty well. And since the exam is repetitive, I mean, this is a non-negotiable. You should not miss easy marks in the knowledge section. Coming to the clinical examination part, if you see, it contains of the physical examination, systems, joints, swellings. For a surgeon, orthopedic exam will be difficult. For an orthopedic person, surgical clinical examination will be difficult. Everything we teach you will tell you what to see, which videos to follow, how to perform where, what is expected of you, how to do your exam and finish your exam and interpret your examination findings in 7 minutes, and how to present it into 3 minutes and answer the questions. This is a checklist for cardiovascular examination. For communication skills, for examination, you should form a team. It should be of 3 people minimum, I think, or two is doable. One should be a patient, one should be a exam candidate as a clinician, and the other one should keep a timer. This is how you review yourself. Initially, it is very difficult to complete all the questions into a 10-minute time frame, 7-minute time frame, but eventually you get into it habit. If you practice enough, you do it in 5 minutes, 6 minutes. And then we have few tricks for you guys to understand, to make sure that you do not miss any finding from the patient. See videos, read the OSCE checklist, practice, give feedback to each other, improvise, make sure that you assess yourself at the end of the day, what you have been wrong, try and improve it, try and inculcate it into your daily practice, and we move. Ortho, ENT, Ophthal, medicine, anesthesia, it can be asked. We have classes for ENT. We have an orthopedician on board. He has an excellent knack of making it easy for surgeons. And I had ankle examination station, and I'm thankful to him. Because of him, it was very easy, despite me not revising it day before. So you understand that even if the station you're not prepared, you should not lose your calm. You should be calm enough to understand that out of 20, 4 marks minimum are there for how you conduct yourself, how you communicate yourself. Other 4 marks are for your decision making skills, and 8 marks then lay into the hands of the examiner. If you do the correct steps, you will get at least 3, 4 out of it. So this is how you manage. You should not fear a station that has come which you are not well prepared for. If you attend classes sincerely, if you do as we say, there won't be any station you haven't prepared. But there might be a rare chance where one of new station comes in and then it becomes difficult. But we will teach you what to do in such case as well. See everything that is given to you into the station. There might be a tongue depressor, there might be a Doppler you need to use. So you have to be aware of your surroundings when you go into the station. Yeah, the systematic way of doing this has to be done in every station where you're going to touch the patient. So anat and patho and microbio not needed, but it should just become your habit. Wash your hands, introduce yourself to the patient, confirm the patient's identity, briefly examine consent. This is basically the briefly explain what you're going to do using a patient-friendly language. You can't be saying that we are going to do a colonoscopy. The patient doesn't understand what a colonoscopy is. You have to make him understand that we will use a camera with a tube which will be passed from a back passage, which will see within of your intestines, and then if needed, we will take some chunk of a tissue from it to identify what is wrong with you. Depending upon the result of the test, we are going to further treat you. So this is you have to understand, you have to make sure that the patient is aware of what all things he or she needs to do before the said procedure, after the procedure, what he can do. He can't drive if he is sedated. So you have to understand that this social scenario there is different. Social scenario here in India is different. So this all things you need to understand and apply. This is the examiner sheet for marking, and we have just highlighted the important things in every domain. This we will be dealing from our end consciously. We will be inculcating it into you. You don't have to go through it if you are with us. Procedure skills, I mean, again, this is very important. There are two procedure skills, and we will be telling you everything. The assistant is usually your examiner. He looks into how you are organizing things, your WHO safety checklist has been followed or not. So these all things matter. Ordering an OT list is one of the easiest of the procedures. Then knot tying will be usually in depth and superficial for basically a bleeding vessel. Abscess drainage is the most common asked, or excision of nevus. Milk catheterization is almost always there for everyone. Then scrubbing and gowning, gloving is a bit difficult. You don't understand that. We have a video for that. Then chest drainage session will be teaching you everything. If everyone has done ATLS, then it is the easier for understanding what is expected and how they tackle the questions which will be put forth to you by the examiner. So cracking the exam code, you should plan your study, how much time you have, what all you need to do, what all your weaknesses. Then you should gather all the sources you are going to refer. I usually ask people not to refer to multiple sources because then it leads to confusion. It is better to stick to one resource. Understand the marking scheme and the stats behind it. On the exam day, make sure that you understand the circuits. What is an empty station versus a rest station? There is a preparatory station as well, just before the communication part, which has been new in last 2 years. So as I said, 7 plus 3. That one is for you to read this time. Then 6 for your assessment of the patient, either history taking or examination, and 3 minutes for you to understand and answer the questions put forth by the examiner. So there is usually a timer or a shout out or a bell, depending on where your exam is. There are stations, which stations we have two examiners, one lay examiner and other examiner. And the 10th minute you have to rotate among the stations. What if I screw up one station? As I told you before, it is okay if you screw up one station. Don't carry the baggage of that station into the another station. It is important to understand that every station you have another life to prepare properly because the examiner doesn't understand. They don't speak in between. You won't understand when the exam begins and the exam ends. Okay, only during a rest session you can gather your thoughts. But I would rather say you enjoy the process, then you will be obviously on the better side of your performances. Make sure that you have water, proper breakfast before you go. If you have an early morning, they usually have English breakfast, so it is not something that we are accustomed to eat in the morning. So have a heavy breakfast and then go. Keep your eyes open. Take clues from all the props kept into the exam station. see the patient hospital. If the patient is admitted, the patient will have a red band in his, her, or her left hand. I think we'll skip this for now, and I'll end the slideshow so that Dr. Vinayak can take you through the communication part. I'll stop sharing. If you have any questions for me, you can ask, or you can text me on WhatsApp, or you can put this into the chats section of the video. Dr. Vinayak, are you there?
Uh, Hey, yeah, Dheeraj. Yeah, thanks, man. I think that was pretty informative. Um, so Dheeraj, so I mean, whatever Dheeraj said is gold here. So he has given you a lot of information. I think the one of the key takeaways is the role of the lay examiner. I cannot emphasize how important that is, because a lot of you are attending this course because some of you have failed the exam. Some of you might end up failing. Many of you will end up passing. But one thing is that, one of the reasons why we started this course was people didn't know why they are failing. And one of the reasons why they fail is because of the lay examiner. And the lay examiner looks at things which is way beyond your comprehension as a international medical graduate. Okay. So you're not tuned to the UK system. And if you're tuned to the UK system, that's why the exams are going to be easier if you're already there in the UK system. But one thing I can assure you is that it is much more easier than part A. So I'll just clear the doubts. I think we have a doubt from Dr. Shrenik. He has asked, is 2 months prepare for a surgeon who's into practice from a long time? Very much enough. Very much enough. So I'll tell you, I did my MRCS Part B during general surgery and MS days. Dheeraj has written that during a very, very busy onco surgery residency, where you are working from say morning 7 o'clock or 8 o'clock till evening 8 o'clock, 9 o'clock, evening rounds and all that sort of stuff. If we both can do it, I think you guys can definitely do it. The only thing is that you will have to attend these classes, or at least even if you have missed one or two of these classes, I want you to make sure that you go through the recordings. People who have failed the exam after attending online classes also, one thing which I've kind of gone through when I've spoken to them is that they have been pretty inconsistent with attending these classes. They've always been like, "ठीक है, recordings are there, so why do I need to attend these classes right now?" No, that is not how it works. Basically, the recordings are intended for emergency situations. They are not intended for daily use, because at least, especially history taking, communication, what do you call? Procedures, examination, it makes a lot of sense if you attend it, because once you're attending, you will not be in a mood to fast forward. You cannot fast forward, see it in 1.5x and all that sort of bullshit doesn't happen, which means that your mind will be focused on the class and you can ask doubts to the examiner at that point of time itself. So yeah, Shubham has asked, how do you prepare for knowledge section, especially anatomy? Yes, we will be detailing. We are going to be having anatomy classes also this time specifically. So that's one thing which I can tell you. And yes, so uh, I'll be letting you know about how to prepare in detail. Yes. So Mayur has asked, it's been a while since Part A. Will it need revision of Part A preparation? No, absolutely not. You don't need it at that level. Can we make a note while history taking? No, ideally not. You don't. You cannot take a note while you can have access to it, but it means that you are not looking at the patient. The only time you actually use a pen and a paper is when you're explaining consent for endoscopy or colonoscopy, or for a procedure where you're going to use some paper to draw a diagram and explain to them. So Shalini has asked, I'm a plastic surgeon practicing for 4 years now. I've passed my Part A a few years ago. I'm now a bit concerned about general anatomy, since I'm now hyper focused on how can, if an MBBS student can do that, you can easily do it. And as a plastic surgeon, you definitely have studied anatomy during your MCH or your DRNB days. So it's not going to be difficult at all. So in the exam, should we actually wash hands for the 1 minute? No, 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 no. That's not normally expected. They expect you to sanitize your hands. So when you're entering the station, uh, the what do you call? You will have to act as if you're doing something, or there'll be a sanitizer you can use it. So Half Khan has asked, is your upcoming videos recorded? Yes, you will have to enroll in the course. You material will be provided online. You will have to, if for those who have enrolled in the course, the videos will be recorded. Yeah. So we'll do a small session. So Priya has asked, can you explain about empty and the secret stations? Dheeraj, do you want to take that question?
Yeah, so there is nothing such as secret station. The empty station is usually for you to rest because there are 17 stations, and it is prudent to have one rest station because it is such an quickly happening exam. If you are unlucky, you will have your first station as a rest station, and then you will have to do the rest of the 17 stations. The preparatory station is just for the communication part, where they will feed you the information a station prior about what is coming into the next station. Supposingly, you're supposed to informing your colleague or your senior about a transfer of a patient to an high dependency unit, post-operative care, whatever may be the reason. So you will have the entire file of the patient in a station prior to it. You have 10 minutes to prepare for it. You can make notes here. You can carry that chit into the another station. If it is a phone call with the consultant, you can definitely carry a chit. If it is in person, we generally recommend not to carry anything because then you kind of lose the point of having eye-to-eye contact and communication. Okay, so secret station, I don't know where the term has come from, but it is just basically to have you equally divided into it. Some exams have two rest stations. Whenever they come, you just take it along with you. Better to keep your eyes and ears attentive because you can sometimes you can hear what are the questions being asked into the stations adjoining to you. If you are aware about it, then you can prepare about the answers. I mean, Dr. Vinayak had one station where he could find the ECG findings. He knew about the ECG findings before into his rest station. So if it is a compartment like station where you can hear what the other person is talking, then it becomes an important thing. Otherwise, I don't think the rest station matters because it is just if it comes in between, it's fine. If it comes too early or too late for you, then it doesn't make sense. If it is the first station, then I think it's just your luck. Don't worry about it. Preparatory session, we will tell you what to prepare, how to prepare in detail, and what to make a note of it. What are the errors that people make, and I mean that will be coming into these individual classes. So I'll restrict myself to that, and if you are registered to us, then you'll understand what we are going to do and how to use those 10 minutes, how to prepare yourself for the next 10 minutes that are going to come. That is all from my side. Over to you, Dr. Vinayak.
Hey, thanks, Dheeraj. So I'll just be spending, what do you call, 10, 15 minutes on a communication introduction. And we'll start off with. So I'm just going to start to answer one question. If the exam is on 5th July and you're not being started preparation yet, postpone. Absolutely not. If you're not started your preparation, that's how I kind of prefer my students to be. In fact, when Dheeraj was about to join the course, he spoke to me. He asked me, should I start preparing? What do I prepare before I attend the course? I did nothing. Come with an open mind. Over the next 1 month, you have more than enough time to prepare. You don't require too much time to prepare, but you need to listen and observe what I say. So, okay, so let's start with communication. So communication is an information giving station where you will be giving information, or where history taking is an information receiving station. No, there's a reason why I talk about this because um, the reason why I'll come to it as we proceed. So how do you communicate? So the setting should be comfortable. So you can follow the spikes protocol. Spikes is S is setting, P is perception, I is invitation, K is knowledge, E is emotions and empathy, S is strategy and summary. Okay. You will be given notes, so you don't need to take notes of what I say. Uh, I'll be sharing it in the students group. So setting is a quiet, comfortable room. And also if they would like to have someone else with them. So obviously in your exam, you're going to be in a quiet, comfortable room. So it's not an issue. But you always ask the patient if they would like to have someone with them, especially in situations where there is going to be some sort of a bad news or some sort of a major decision to be taken, like a DNAR form to be filled, or you're going to give them the diagnosis of a malignancy. P, perception. Perception is very important. Perception is where you assess the knowledge of the patient. So you will not start off by saying, oh, Mr. Smith, your mother is very sick. And We have run the tests and we have kind of, found out that there is a lung malignancy, nothing of that sort. You will have to ask them, Mr. Smith, what do you know of your mother's condition till now? Do you know what treatment has been given till now? Discuss the symptoms which they are suffering from. See, one of the key things is that we are men and women of science, which means that we are focused on solving problems. Okay. So if a patient comes to you with, say, breast cancer, our aim is how do I start her on chemotherapy? We'll explain about chemotherapy and all that sort of stuff. But if you communicate with her very well, you will find out that her major aim is not breast cancer. She has accepted the diagnosis that she's having metastatic breast cancer. Her major problem is the fact that she's suffering from pain due to vertebral metastasis. So her only concern is the pain due to the vertebral metastasis. If you're not able to address it well, the lay examiner is going to fail you. The other thing about perception is you will have to assess the patient's emotional state. You don't have to talk about it to the examiner or the person, but you will have to do an assessment and you will have to behave according to that assessment. Okay. And there's always a concept called as a warning shot. Warning shot is before you give some sort of a bad news, you tell them, okay, there is an issue, but and it's not really good. You tell them that thing. That is also a part of perception. I'll be explaining it to you how to go about doing that. Okay. Next is invitation. Invitation, is a concept where you ask the patient whether they are ready to accept the information today. In one of my earlier classes, when I was speaking to about this, a person had a very good question. He said, "Sir, we have come to meet the doctor. They come to meet a doctor, they mean that they are ready to receive information. But that's not how the system works. I understand your logic, but that's not how the system works. K is knowledge. Knowledge is what is the chunk, is the most important part of your communication. That's where you're telling them, the patient, what the problem is, or what procedure they're going to undergo, or what form they have to sign, or what information you have in mind you have to give. That is the knowledge part of it. Now, there is a way of doing that. You don't deliver information in monologues. You deliver information in chunks. So, you say something and then you give a pause. It's what I like to call as a pregnant pause. There's a lot of meaning in that pause. You give that pause to assess how the patient is responding to that information. Okay. And E is emotions and empathy. Empathy, I'll tell you how to demonstrate empathy, how to sit, how to talk, how to offer water, how to offer tissues and everything. Last one is summarizing. So I'm going to ask you a question. You guys are going to respond in the chat. You will have to respond in the chat. It's a rule. So who does the summary in a communication station? Is it the patient or is it is it going to be you? Guys, you will have to respond. Is it the candidate or the patient? Now, in communication, in history taking, now who's going to summarize? Is it going to be the patient or is it going to be the candidate? Okay. So the concept is very simple. Whoever is receiving information summarizes. So most of you have made a mistake into this. Many of you have made some mistake, but whoever is receiving information summarizes. Okay. In communication, you are the information giver. The information is received by the patient or the attender, right? So the attender or the patient summarizes. Okay. In history taking, you are the information receiver. The patient is giving you the history. So you will be summarizing. Okay. There is a concept in that. Okay. The concept is that you are checking how much the patient is able to understand what you have told. Okay. So only when he is summarizing, you are able to understand what, you know, whether they've understood the information or not. The most important thing in communication or history taking is the concept of ICE: ideas, concerns, and expectation. Okay. Like I told you, you might have a very different purpose for this communication, but the patient will have a completely different perspective. The patient will come to you with a small rectal bleed. There is no indication that it could be cancer. It appears, like a splash in the pan. It appears like, a hemorrhoids. Patient is giving history of constipation for many years. Hemorrhoids. There is a visible hemorrhoids and everything. The GPS said it's hemorrhoids and you are referred as well. But the patient's concern is not about the surgery. You can explain about the surgery. You can explain about hemorrhoids. That's not the concern. The concern of the patient is that his mother's friend died of colorectal cancer and he also had bleeding to her rectum. Okay. So if you cannot address that concern in this communication station, that means ultimately how much ever well you have communicated from your perspective, you will fail. I'm going to be very brutal about this. If you cannot address the ideas, concern, and expectations of the patient, you will fail. Okay. So I'm going to call for volunteers. I'm going to call Dr. Yash Verenkar. See, one of the problems in this thing is that uh, I can call anyone for Yash. Are you there? You guys will have to be ready. Are you in a position to be the candidate right now for our first station?
Yes, sir.
Yeah.
Okay, sir.
Yeah. You'll have to switch on your video. Is that possible?
Sure, sir.
Hey, Yash. Hi, man.
Sir. Yes, sir.
Yeah. So we're going to be doing a station today. We're not going to be taking too much time. It's going to be a Breaking Bad news station. We are not going to be doing the full station today. We're going to be doing it tomorrow, where we'll be doing 2 or 3 stations. But today, we're going to be doing introductions. Okay. How do you introduce yourself when you start? Okay. Situation is going to be the same. Okay. And let's see. Okay. Your STEM is 75-year-old Mrs. Kumar comes with a severe cough. And investigations have revealed it to be CA lung with metastasis to bone and brain. Listen carefully. Dr. Ajay, who is a thoracic surgery consultant, has signed the do not attempt to resuscitate order because he feels CPR will be futile in such terminal malignancy. You are Dr. Pravi. You are Dr. Yash. You're a specialist register in the unit who is asked to speak about the patient's son about the terminal malignancy and DNAR. Okay. So,
Okay, sir.
so the funda over here, I'm going to give you you have 1 minute, but I'm going to give you only 45 seconds. Think about it. For the others, so what are the things you have to remember from this step? The names are very important. Okay. You cannot make a mistake in the patient's name, the doctor's, your consultant's name. Your name will not be usually be given. But in some stations, I have very rarely heard that, even the candidate's name is going to be given. But right now, they don't do that. They allow you to use your own name. But names are super important. If you're unable to understand the pronunciation of a name, it's not going to be a problem for those who are writing in the subcontinent. If you're writing, in Chennai in July, you're not going to have an unpronounceable British name. That's not going to be there. You're going to have some sort of an Indian name, so it's not going to be difficult for you. But if you're writing an exam in the UK or in Malaysia and you don't, or in Egypt, and you don't understand the pronunciation of the name, you go ask the patient and the attender, am I pronouncing it right, or how do I pronounce it? Number one. Number two, name of the consultant. Here I told Dr. Ajay. Look at this name very carefully. If it's Dr. Ajay, it's Dr. Ajay. If it's Mr. Ajay, it's Mr. Ajay. Because in the UK, post FRCS, you become Mr. You are not doctor. Okay. It's considered disrespectful for a person who has finished FRCS to be called as doctor. Okay. I have not completed FRCS. I'm still Dr. Vinayak Rangan. But if I complete FRCS one day, I automatically become Mr. Vinayak Rangan. Okay. So this is something you have to remember. Okay. So, and don't misgender. If you have a doubt about this thing, you can ask, but make sure that you don't mess up on male, female, and all that sort of stuff. Okay. Usually it will be very clear, Miss Kumar, Mrs. Kumar, and all. But if only the name is given, a patient, be very careful while understanding if you're not sure about it. Okay. Okay. So yeah, Yash, we can start. I am the patient's son.
A very good evening, Mr. Kumar. I'm Dr. Ajay. I'm a cardiothoracic surgeon, and I'll be seeing your mother today.
Stop. You are Dr. Yash and you are the specialist register who is working with Dr. Ajay.
Dr. Ajay.
Okay. So again, you made a
Okay.
mistake in the name. Yeah, come again. You are working with Dr. Ajay. Okay, start again.
A very good evening, Mr. Kumar. Dr. Yash. I am the cardiothoracic surgeon, and I'm working with the consultant cardiothoracic surgeon who's seeing your
Stop.
case, Dr. Ajay.
Stop. What mistake did you make? Like very clearly in
And
the
I
slide.
am the cardiothoracic surgeon.
Yeah, I had mentioned he's a specialist register. Shalini has got it.
Register.
Okay, so now you have made a mistake in introduction. So this will make sure that you lose marks in this. Okay, because you're misrepresenting yourself. Okay. So start again.
Very good evening, Mr. Kumar. I'm Dr. Yash. I'm the surgical registrar. I'm working under Dr. Ajay, who is the cardiothoracic surgeon who's looking after your case.
Stop. What mistake did you make here? I'm sorry for being brutal. I'm going to stop you again and again if you're making mistakes so that you guys remember it. So what mistake? Yes, Dr. Praveen has got it. Case. You're talking about patients. You're not handling your case. Okay, and it's his mother, first of all, and you're talking about this thing. So I'm going to be doing it. Okay. I'm going to be introducing myself and I'm going to be teaching. The first mistake you made was you didn't do this action. You're entering the room. The moment you're entering the room, you'll have to do as if you're, washing your hands like this. And that's it, you enter. It's 1 mark. You are not missing that 1 mark. I'm personally traumatized if any Mortimer Green student loses that 1 mark. Okay, I can't sleep if you guys make that mistake. Because I'm going to be emphasizing it again and again. And Dheeraj has already told you about this. Okay. So don't keep talking. Don't introduce your monologues. Okay. So just start off by, hello, Mr. Kumar. Wait. And then say, I'm Mr. Vinay. I'm Dr. Vinay. I'm the specialist register working with Dr. Ajay, who's the thoracic surgery consultant. Okay. So wait, he will tell you. Okay. Whatever the second. And then what you do. Then next, what would you do, Yash? Now that your greeting is done, hi, how are you? All that sort of stuff is done. Then what do you do next?
Meet and greet introduction is done. And
Yeah.
I will ask Mr. Kumar, what do you know about your mother's condition?
So I'm going to stop you again. Okay. So how do you know he is her son?
Okay. Confirm the identity of the.
Perfect. So now you will have to confirm the identity. Okay. So when you're confirming the identity, what are the things you want to ask? There are 3 things you ask. So basically what you need to do is the 3 identities and all are there in the procedures. That's kind of this thing. But in your communication setting, you act as if you're looking at a paper and ask, may I know your mother's date of birth, Mr. Kumar? May I know your name and your mother's date of birth? So you already have the date of birth. He will say some date of birth, and you'll say, thank you, Mr. Kumar. Okay. So that's how you do. Okay. So you want to do that again and practice it?
Sure, sir.
Yeah. Don't call me sir. It's Vinayak. Okay. So yeah, you can't call anyone sir. So yeah. So yeah, start.
A very good evening, Mr. Kumar. I'm Dr. Yash. I'm the surgical registrar. I'm working along with Dr. Ajay, who is the consultant cardiothoracic surgeon who is looking after your mother's case.
No case. No.
Mr. Kumar, may I,
That's it.
who's
Anyway.
looking after your mother?
Hello, Dr. Yash.
As I'm seeing over here, Mr. Kumar.
Huh?
Yeah. As I'm looking at your case,
No,
May I
never
know
saying
your
yes.
full name, Mr. Kumar?
Yeah, I'm Vinayak Kumar, doctor.
Yeah, good evening, Mr. Kumar. I would like to know I see here that your mother you have brought to the hospital. May I know her date of birth, if you don't mind, Mr. Kumar?
No, doctor, I don't mind at all. She was born on 23rd March 1952.
Thank you for providing that information, Mr. Kumar. So I would like to discuss more about your mother.
Okay, doctor.
What is happening with her today? Why did you bring her to the hospital today?
Hey, so I'm going to stop you again here, Yash. Okay, I have not given you any information when she was bought. So right now you are fabricating, correct?
Yeah.
So in this time, I just told her that she's been diagnosed. Okay, I have not said that to bought today or anything of that sort. Okay, so all you need to do is that she might have been bought a couple of days ago. We have done investigation, so investigation is not going to be done in a day. So it means that she's been here for a while. Okay, so which means that you will have to ask an open-ended question. Okay, the most important open-ended question is going to be very simple stuff. Mr. Kumar, what do you know about your mother's condition? Okay, so that's how you start. Okay, now I will give you a lot of information, and then because it's a breaking bad news and a DNAR, next question you ask is ask if someone else wants to be with you. Okay, so that's how you are going to be doing the introduction. So tomorrow we will be continuing the station. We'll be starting from the first again. I'm going to be asking Yash again to do that. But today I'm going to give a homework to two of you. So it's going to be three of you. In fact, it's going to be for Dr. Hema, Dr. Yash, and Dr. Karthik. Ankur, please make a note of this. So today, all three of you are going to record a video and send it to me. Okay. So you record it by tomorrow afternoon. You are going to send this to me. You're going to do an introduction for the same station. You can use your own names. Dr. Hema can use her own name. Dr. Karthik can use his own name and sing it. And you are going to be giving me a small video where you introduce yourself and ask what do you call confirm the identity and relation. Is that okay? Dr. Hema and Dr. Karthik, please do confirm. Hema is confirmed. Karthik, perfect. So are we set for tomorrow's class? So tomorrow again, same time we'll be meeting, and we will be doing at least 2 to 3 communication stations. It's going to be a long session tomorrow, and I want you guys to be focused with me. Okay. Okay, guys. So Ankur, if you can post Mortimer Green's official number over here, it'll be great. Anybody who wants to enroll in the class, you can just contact Mortimer Green, and we'll be helping you enroll. Okay. Okay, guys. And for those who have enrolled, thank you so much. Me, Dr. Rohan, both the Dr. Praveens, Dr. Dheeraj, and Dr. Kumar are going to be working hard to make sure that you pass your exam, and that's a personal responsibility we are going to be taking. But on the other hand, I would require that sort of a personal commitment from your side as well. Is that okay, guys? Thank you so much. Have a good day.